Hello, everybody, and welcome to the 34th installment of the Phenotype Speaker Series. We're excited to have everybody rolling in here. It's lunch on the East Coast, breakfast on the West Coast. I can't do other time zones in my head. Hopefully, everybody has a drink or a snack or a meal with them so that you can enjoy our webinar today. I'm your host, Dineen. We're going to be talking about proving profitability in genomics, all about the money today. So thank you, everybody who is joining. We have a fantastic panel here, as you can see. We've got four experts on the call, and I have so many questions. If you have tuned in before, you know that I'm a very curious person. I have so many questions, but I want to make sure we get to your questions. So throughout our webinar, please, if you are listening to this live, watching it live, submit your questions through the Zoom Q&A box, and we will get to those at the end. But I don't want you to wait to the end because then you're going to forget your question. So just put it in as you think of them. I think everybody is familiar with Phenotyps at this point. Phenotyps is a complete EHR integrated solution for medical genetics. They have software and services that ease our workflows as genetic professionals and improve our efficiency. Phenotyp's genomic health record includes tools like inclusive pedigree builders, automated pedigrees, human phenotype ontology capture, built-in cancer risk assessment, diagnostic insights, so much. If you haven't checked it out, please make sure you do. We have all experienced how electronic health records are not built for genetics. So the genomic health record fills in those gaps by providing a unified and seamless genetic workflow. And it's ideal for managing increasing demand of genetic services that we are all experiencing. So as I mentioned, I'm Dineen. I am your host for this webinar. My pronouns are she, her. I also host a podcast, which most of our guests have been on. Marianne, we got to get you on at some point, called DNA Today. We've won the podcast award for Best Science and Medicine award, show for the last few years. We've have over 350 episodes in the last decade, and our genetic conversations are super similar to what we have today. And I think since, well, maybe we've had one. I've launched a science podcast network called Gene Pool Media that we have a lot of the shows under, and including this one. But enough about me. I'm the least important person on the call today. So I want everybody to introduce themselves. Colleen, can you start us out?
Sure. Colleen Campbell. I am the Director of Genetic Counseling Operations at the University of Iowa Healthcare and the immediate past president of the National Society of Genetic Counselors. But I'm speaking today under my university hat. Thank you, Kira.
And Eric, I'll have you introduce yourself next.
Sure. Eric Green, trained as a physician scientist, participant of the Human Genome Project. I was at the National Human Genome Research Institute for over 3 decades, serving as the director for a little over 15 years. I departed there in March of this year.
And Marianne.
Hi, I'm Marianne Olson. I'm a prenatal genetic counselor currently working at Baptist Health in Kentucky in MFM offices. I published last year on the downstream revenue following cardiac genetic counseling appointments at a pediatric hospital.
And Brian, round us out.
Y'all, I'm Brian Reys. I'm a genetic counselor, I work in cancer at UT Southwestern, and I serve NSGC as a CPT advisor.
Amazing. So we have an awesome conversation ahead of us. And just a reminder, everybody, put your questions in the Q&A box. I want to see what everybody's thinking about and how we spark curiosity during our conversation. I figured we could start with why genetic services are so often thought of as cost sinks, that when I'm in conversations with people and talking about the money side of genetics and the finances, sometimes I hear about, oh, well, that genetic position or this department, like we actually lose money. Why is that the case? Does anyone want to start us out?
I'm probably the least qualified as the non-practitioner here, but
Go for it.
I know enough to say, for example, it's not very procedure oriented. So, that's one of the ways clinical revenue can get generated, as an example. And that is often the driving force when people look at cost recovery, what do you get out of investments and things. But I'm sure the genetic counselors have even stronger ideas of the various arguments.
Yeah, Colleen, what are your thoughts?
I would echo what Eric said. The procedures are very much a driving factor in hospital financial discussions. The other thing I would add is often I find that people conflate genetic testing and genetic counseling. And so they'll hear really expensive genetic tests, and those might not be well reimbursed. And then they assume that also applies to the genetic counseling, where it may or may not be true. And so trying to tease those apart a little bit can also be helpful. But I think the number one reason is the procedures.
Yeah, I think that's a great point of just how we're able to have revenue come through. And I also think about, while we have Colleen and Brian here, I feel like I have to ask, how much does our billing code, especially the new one as of January 2025, which you guys actually came on DNA today to talk about that new billing code after NSGC last year, how much does that play a role, just how billing codes are, Brian?
Yeah, I think that especially when we talk about consultative services versus procedure services, the change in the billing code is really important for genetic counselors. We knew that we weren't capturing time that we were spending on the data service, both prepping to see the patient, but also writing our notes, things that we spend a lot of time doing. I don't know about y'all, but my notes are quite lengthy. And with the new code, being able to really capture that time in a billable way has made a huge difference. And it's time to shout that to hospital administrations so that they know that this has changed and that the conversation for genetic counselors is different than it was last year.
Yeah, I think that's so important. Colleen?
I would just agree. I think one of the questions I often am asked by hospital leadership is, okay, well, if they have 10 appointments in a week or 12 appointments or 20 appointments, what do they do with the rest of their time? And so that new code does allow us to demonstrate for hospital leadership what the genetic counselors are actually doing with their time and make sure we're capturing it. So it's very, very helpful in that sense.
Do we need more time? Because it's only been going for like 9 months at this point. Do we need more time to have a better sense of the ROI on this new code compared to the old one?
When we start looking at the data, the math is pretty easy. Anytime that you were spending on the data service pre or post your consultation can now be captured. And so what we really need the time to figure out is, are genetic counselors changing their behaviors at all? Were some of us having some maybe poor practice behaviors where we were potentially noting after the date of service, which a lot of studies suggest that for both memory recall, also getting your notes done, and for billing efficiency, it's best to do that type of thing on the date of service. So what I think will be really interesting to see is whether or not this will prompt any practices to change their habits, hopefully in a meaningful and beneficial way.
One point I think that's worth pausing and pointing out is sort of the nature of genetics and genomics today. I mean, everything's changing every day because we're amassing new information, we're amassing, new strategies. The technologies still are getting better and better, and what that then requires is a sort of continual adaptation. I'm guessing, certainly for all profession, clinicians, but when I say clinician, I mean physicians, nurses, genetic counselors, pharmacists, physicians, et cetera, because the earth is moving under everybody's feet. But that's a good thing because it's getting better all the time. But however, that doesn't necessarily mean that everything is perfectly efficient, because to advance the practice of all of this, it has a little bit of a short-term investment to get long-term benefits, but it all depends on the distance with which you're looking into the future to say, I need to see, full cost recovery, profitability, any of these, I need a business case, et cetera, et cetera. All that's really much more straightforward when everything's stable. And the wonders of genetics and genomics is that nothing's stable because it's getting better every day. So I don't know. I just always think that has to be factored in. And I expect that everybody on this panel is dealing with their, the hospital administrators, university administrators, all the, business folks, all that. And we've got to continually emphasize that. And I'm sure you're going to be faced with mixed reception to, or mixed sympathies to that. In the long run, this is great for humanity. In the short run, it might not be the best thing for a given budgetary situation at an organization, a hospital, a university, et cetera.
Along those lines, I would add, we do need, hopefully the practices are starting to change. I know like at my own institution, we tried to move away from clinic days, admin days, and try to have a more even schedule to maximize our capturing what we could for reimbursing those counselor services. You turn that on and there's still going to be time, this lag where you have to drop the bills, it has to get processed, the hospital has to see what they get reimbursed. So I think we still don't have a really great picture yet on what this is going to look like, and we do need more time that way. The other place where I think we need more time is we did know when we were changing this code that there would be a lag with the payers. And so we need that time to also have the payers recognize the new code. We know there's some payers that were recognizing old code and now need to be updated on the new code, or they may just be reimbursing like a set rate and not recognizing the timed intervals, which is very important with the new code. So I think we do need some more time to work through those. And that's where NSGC has made a really large investment in working with payers from Medicaid and commercial to try to improve the recognition of that code so that you can see this. So to Eric's point, like it is kind of an evolving picture that we're going to be seeing.
Colleen, I'm so glad you mentioned that, because especially as we talk about the payer landscape, people ask me, well, yeah, we have the new code, but is it causing more pain than it's worth? And the answer is absolutely that the code is undeniably beneficial, but we do have to work through the pain points. And so if you are at a practice and your administration is saying, oh, we're getting denials, we should lean into that and say, okay, why are we getting these denials? What resources does our hospital have to reach out to those payers and provide them education? Some of our efforts have been incredibly successful, especially with the national payers. But we try and emphasize this, there are over 1,000 payers in the United States, and that's the payers. That's not even all the thousands and thousands of plans that they have. Mm-hmm. And so this is the time for our field to really lean into this. Message in SGC if you're having pain points. There's a denial guide that you can follow. There's a lot of resources that exist to help practices work through this.
And I love that leaning in, Brian, because like that's exactly it. Like one of the payers we have here in Iowa, they reimburse, but it's a set fee. And so I've been pushing finance. I'm sure they're very annoyed with me now on the phone daily with them, but pushing them to say like, hey, we have an opportunity to do better. We have an opportunity to capture more of revenue for the time that the counselors are spending. And let's use this new code as that opportunity to go in and have those conversations to do better.
Yeah, no, that's a great point, because we need to just be putting it in. And if we're getting those rejections and denials, it's like we've got to follow up with it and not just be like, oh, well, yeah, I guess that's how that goes, because you got to fight it until it happens, because, there was a lot of work, including Colleen and Brian's work, to get this code to be real and updated. So we all, I feel like, they put so much work into this. We need to actually be able to use that new code as genetic counselors. One thing I wanted to get into is, I guess I want to talk about like the downstream revenue, but before I get there, I also wanted to hit a little bit more on like the return on investment. And Eric, I'm thinking, you as the former director of NHGRI, which for those that don't know, the way I've explained it to people, which obviously, correct me if there's a better way to explain it, but the genetics part of NIH. So you've also just spent decades at the NIH. So you have just so much experience. Can you elaborate on like what the return of investment on genetics and genomic research is? Yeah. Because I hear stats in terms of, well, for every dollar the NIH spends, we get this much more in the economy. Enlighten me on what I got wrong there and how that really works.
Well, no, you got it right. I mean, I maybe just sort of give a few more details. So, I mean, the National Human Genome Research Institute, where I was for 3 decades, plus was created by the U.S. Congress to lead the U.S.'s effort of the Human Genome Project. When the Genome Project ended in 2003, the Institute did a pivot to basically be the central hub for genomics and genetics at NIH, among being one of the 27 institutes and centers that make up the NIH. Of course, all the institutes and centers do genetics and genomics, but what we've done is really disseminate the expertise, increasingly try to raise everybody's boat. And I can tell you that NIH routinely, as you point out, tries to analyze its return on investment for research dollars. It's used as a means to continually convince the Congress, the President of the United States, and so forth that this is good for the U.S. economy, and it absolutely is. And there's lots and lots of studies and lots of ways of analyzing this. So it's an important point, but of course it's really about basic translational and clinical research and how that stimulates the economy more broadly. It's illustrative of the principles, I'm sure, that are used in thinking about healthcare systems and the use of any testing modality like genetic and genomic testing. So that's where I know it gets relevant to the broader discussion we're having today. But it is different. It is important to keep it in mind. It's not, NIH is not about getting return on investment for clinical practice. It's more about the broader biomedical ecosystem, which is big and complicated and has many aspects to it, including therapeutic development. Drilling down at genomics, and I think this is part of what you're referring to, Kira, is, genomics, we've been super proud when people have looked in the rear view mirror of the Human Genome Project, and it's the investment of something like $3 billion. It wasn't all US money, but it was because it was an international project. Other funders came in, but something like $3 billion got invested. And the question was, even if you just looked at the US economy, how much innovation, how much economic stimulation came out of the Human Genome Project. And these were done, various studies have been done. I would encourage the viewers who don't know about this to Google it, and you could read all sorts of very complicated reports. I'm not sure, it's not my area of expertise, but there were some very strong experts who did weigh in on this. There's a famous report called the Battelle Report as one of them. And then there was another follow-up. Bottom line is, it depends, the methodologies, depends which report, and they did it a couple different times, and they've gone back and visited it. One report said 141 to 1 in return on investment. So for every dollar of the Genome Project got $141 of economic stimulation in the United States. Another report said more like 60 or 65 to 1, whatever. It's a great return on investment. These are hard numbers to calculate, but if nothing else, just think about, if you sort of look across it, just imagine, some of the basic information coming out of the Genome Project, not to mention all the technology development that subsequently went in with new methods for sequencing DNA and new companies and this, that. Needless to say, it's very clear that overall genomics is a stimulant of economic development. Now, though, it's really getting to the adult table, instead of the kids' table. I mean, now we're really serious. We're into healthcare. There's a complicated, rough and tumble ecosystem where we've got to eventually demonstrate our value, and I think it's going to happen. But it's you got to be in it for the long game. That's a theme I'll probably come back to a few times today.
Yeah, I mean, it's called return on investment. You have to invest money, and then it comes later. And I think, especially Eric, you being part of the Human Genome Project, like that is, I can't think of a better example of we poured a lot of money into this and many, many years, but look at the outcome of all of these companies and all of the other research and discoveries that has happened, and even now treatments for certain genetic disorders. We wouldn't be where we are today without the Human Genome Project being done.
I mean, and it's all a matter of how patient are you. And, if you want a return on investment in a week versus a month versus a year versus
then you should not be in research.
Yeah, I mean, you got to measure these things in decades.
Yeah, no, it's a really good point. So that's the investing. That's the beginning end. I want to move us down the line now and talk about downstream revenue. So, Marianne, you were published in the Journal of Genetic Counseling, I think it was last year, right? And your paper was Cardiac Genetic Counseling Services, Exploring Downstream Revenue in a Pediatric Medical Center. So can you tell us about your publication and what you learned out of this?
Yeah. So when we're talking about the billing codes and the day of service and getting the reimbursement for those services, that's what we think of as the direct revenue. How much is the institution earning from that visit? But in genetics, we know we're not just one point in time and we're not just one person is our patient. Really, we're serving a whole family and we're serving that patient. We're making recommendations, possibly lifelong recommendations for them at our one appointment. So in our paper, we were looking at the downstream revenue following a cardiac genetic counseling appointment. So at Cincinnati Children's, where I was a graduate student, worked on my thesis, and in this department, we'd see patients across the lifespan, pediatric, adults, even fetal. And what we did was we looked at a few indications and said, all right, for these patients, what did they come back for in the year following this appointment? And their family members, we include family as well, for their pediatric family members, what did they come back for in the year following genetic counseling appointment? Was it linked to our genetic counseling appointment? And what was the revenue of that? So we found, a lot of folks came back for example, a cardiology appointment, an echocardiogram, and an EKG. And we found that there was significant revenue. And our population was a pediatric population. This is not, in general, mostly not a critically ill population. This was mostly screening for healthy individuals, but we found significant revenue. It was also only a small slice of the patient population, but we found that considering this longer lens of the financial impact of genetic counselors does make a difference.
Yeah, I think that's such a good point, that especially the way we started our conversation of like, why is genetics sometimes thought of or considered as a cost sink? Because we're ourselves as genetic counselors and geneticists not billing for procedures. However, you make such a good connection there of, if it wasn't for at least a good chunk of these kids getting the genetic diagnosis of some kind of cardiac condition or genetic condition that has cardiac symptoms and findings, then all of those follow-up tests and maybe even surgeries wouldn't have happened.
Yeah. So we have, patients who, because a family member was tested positive for, let's say, an MYH7 variant, now their nieces and nephews, not just their children, but their nieces and nephews can get tested. Those who are negative can get released from that risk. Those who are positive will get that annual procedure, the annual follow-up and appointment. So there is that connection. Again, we might not see those patients every year, but they're seeing cardiology every year.
Yeah, no, that's such a good point. Like anything with genetics, it's not just that one patient. It's like, as soon as you have that, and then it just cascades and spans out to everybody else. Brian, you've been involved with researching the downstream revenue. Any other thoughts with this, or what people should be thinking about or appreciating?
Definitely. And shout out to Cincy alum, Marianne. I'm so proud of you and your whole team. That work was fantastic. We were working on this really before the new CPT code, and we were thinking about, there is this portion of our GC salaries that just isn't being met by our current needs when we were looking at our own financial data. And yet we're part of a cancer center team, at least my practice is. And we know that in cancer in particular, there are a lot of procedures being done. There's significant hospital revenue. And what we wanted to do with the papers that I worked on in downstream revenue was really look at where the genetic counselor sits in that conversation, and particularly where we sit as it comes to new patients to the hospital. So while those papers, a lot of people will look at them and say, wow, these numbers are just huge, they're in the millions of dollars, we recognize that that's because cancer centers are supporting many, many staff members besides genetic counselors that contribute to a patient's experience. But what we want people to take away when reading those papers is that genetic counselors who saw what we called naive patients, but what we mean by that is patients that had never been to the hospital before they saw the genetic counselor. Think about your cascade testing patients that come to see you and then stay at the hospital because they enjoyed your care and because now they're connected through you. We looked at those patients, and just those patients alone matched a genetic counselor's salary and their downstream revenue in the subsequent years that they saw a genetic counselor. And a typical volume by an NSGC by counselors seeing NSGC typical volumes per the PSS. So that was huge because it was really also more about changing the conversation to say, hey, by being a warm, beneficial caretaker that then encourages people to receive care at our hospital, genetic counselors are also contributing to the overall budget, and that can make up the remainder of our salary that consultative services are not doing. And that was all before the new CPT code.
Wow. Marianne, yeah.
Yeah, like we've seen research and we inherently know the value of a genetic counselor for a patient. That warm environment, that support in decision making in a sometimes difficult discussion, and inviting those patients in, serving them, so valuable. At the same time, we want the efforts to be sustainable, and we want to be able to fund our positions. We want to make a case to hospital administration that, yes, we're valuable to patients, but also we can move toward being revenue neutral or even revenue generating. And that's with the downstream revenue, that's a piece that we've been able to really add to the discussion.
Yeah, that's so important. And what I'm hearing and what I expected to hear today is that genetics is not a cost sink. Can we all like agree on that? I think that looking at all of these downstream effects and all of the money that comes into that, one thing that I don't really know and I want to learn more from you, Colleen, is what are business cases and why does genetics in particular benefit from them? So just kind of that general, what is it before we get into what you've built?
Yeah. Given a lot of us are probably more familiar with grants, I think of a business case as the business world's version of a grant. There's usually a specific structure or information that's in there, including, what is the problem? What's the rationale for initiating this project or investment or a strategic decision? And then what are the proposed solutions, the benefits, the risks, the key strategic challenges, and then the financials, and how those all kind of come to play in whether you pursue or not pursue this. So a lot of those things are very similar to a grant, like you have a problem, how you're going to address it, what you expect the outcomes to be. It's very similar, but a different structure, and written slightly differently. But that's the easiest way to think of it.
Amazing. And can you share a little bit more about the business case you built for University of Iowa? I think it was like 10 years ago, right?
Yeah, it's 10 years ago. We need to write it up. We hadn't written it up because I didn't want to jinx things, but now that we're 10 years out, I feel a little more comfortable. So what happened at the University of Iowa is that our vice president of healthcare at the time wanted a graduate program. And in fact, there were 0 genetic counselors that specialized in prenatal or cancer in the entire state in 2013. And so I knew there was no way we'd be accredited. I said, no, you get called to the principal's office, essentially, and went in with data showing why, what the problems were in Iowa. He then charged me with writing that business proposal. I think he thought I would not know what to do. And then he would still get, just keep telling me to do the program. But I had a friend in business school who taught me about business cases and helped me outline it, and then, went through and wrote it. I think the key with it was that it wasn't something that you can create, overnight. I did a lot of research. I spent like a year talking to genetics departments around the country, what works, what doesn't work. And then you have to tailor it for your own institution and what's going to work there, because my institution isn't the same as Brian's or Marianne's. They're all going to be different, and you need to think about the politics as well as the resources and everything. I think the other thing that was really helpful for us is that we had advocates that were outside of genetics. So for better or for worse, our cancer center was losing oncologists because they didn't have genetic counselors and they were struggling to recruit. We also were obtaining new neurologists and cardiologists who were demanding genetic counselors as part of their recruitment package. So all of this was happening simultaneously. And ultimately, the performance, our business case was for over $8.5 million, and it was ultimately green-lighted. And what was really nice is that the business case also outlined, here's all the issues, and here's our strategies for solving it. So we had a really nice roadmap that we were able to then go through and implement once we had the green light.
Wow.
And I think when you work in that space and you learn to talk the talk of the decision makers, it can be really helpful.
Can I ask a naive question? Because I actually want to know
Yeah.
what is a greater hurdle? Is it getting the business case for genetic counseling or getting the business case for the genomic testing? And does it vary in different circumstances? Because I mean, obviously, what you just described, Colleen, and what the three of you are talking a lot about is sort of the whole economic and business models associated with genetic counseling. But that's only part of the barriers. There's also lots of barriers around willingness to pay for exome sequencing, genome sequencing, panel sequence, blah blah blah. Is one worse? Is one notoriously and consistently worse than the other, or does it depend on the circumstance, the clinical situation, and the institution?
Yeah, I'm curious what others think. I would say in our situation, we were separating it out. The cost of the testing has been changing a lot faster than the cost of the genetic counseling service model, right? And so when we built ours, it was focused on the service model, and the genomic testing would be downstream of that. I haven't, in all honesty, made a business case for genomic testing. I've had some presented to me, even as recently as last week. A company presented one to me. I think that we're seeing more of those with the Project Baby Bear and the Project Baby Deer and all the Baby Seek projects. So I think we're seeing some of that, but I can't speak personally to which is harder to do. I would say one's with payers and one's with your institutional leadership. And I've gone through several institutional leadership changes in the last 10 years, and I'd say some are going to be probably equally as hard as a payer, and some are going to be easier than a payer. So probably highly variable, but I don't know what others think on that one.
Marianne, what do you think?
Yeah, so in the clinic, I think that there's kind of a on the boots on the ground approach to funding the test for the individual patient. So depending on your hospital, you may have institutional billing where your hospital has to make an agreement with a lab to bill the hospital, and then the hospital bills the patient. But in other settings, we do direct to patient billing. And so maybe surprisingly large amount of my job is knowing which lab is most likely to be like a go-between between my patient and between their insurance company to get reasonable coverage for this genetic test. And so it depends, again, on institutional or direct billing. I think likely is a little different everywhere. And I don't have as much experience with working with the hospital administration, but I do know that there's just a lot of moving pieces with the test coverage in the clinical setting.
And one of those biggest pieces is state laws. There are quite a few states now that recognize tumor testing, especially for cancer, as a required service through a state provision, but that's roughly a third of states at this point. Some of those similar laws also cover other genetic provisions like whole exome and whole genome and pediatrics, but it's very state specific. And so I imagine that this conversation is really reliant on, are you talking about genomic services through your own institution? Are you talking about them through a third-party laboratory? And what state do you exist in?
Yeah. I'd also add there's probably more players involved with the genomic testing piece, right? So you're going to have patient advocacy groups and labs and others that are all going to be advocating. Whereas if you're building a business case for a service line in your institution, there's probably not as many. You do need to engage other people, but there's probably not a lot of people who are like, hey, let's just do this, coming to you with the idea. So I think that might be the other big difference. But I think both are possible. They just would be different approaches.
But it really illustrates the multidimensional challenges of this fundamental question that we're talking about today.
Definitely.
And I don't point flip to audio, or sorry, and was there something else you wanted to add in?
I was going to say that I also don't have experience on the lab side, and I imagine this question from the lab genetic counselors and the lab administration who are trying to come up with pricing models for their tests and work with insurance models on that side is a whole nother can of worms.
Yeah, and I also think part of the reason I'm pointing this out is, what the other panelists talk about very practical, everyday things they're dealing with here and now. But I think all of us are involved in many conversations, or at least hypothetical conversations. Some of them are real conversations that might eventually lead to change. But thinking about a future, which maybe is less than a decade off, where every newborn gets a genome sequenced, and that's going to be a huge, need of money to do that, with presumed long-term gains. But these experiments are really, if you call them experiments, these are really happening in other countries, and we're going to learn a lot from that. And I think some of the things we're discussing here at a micro-ish level are going to be discussed at a macro-ish level if we think about seismic new approaches to things, such as expanding newborn screening to whole genome sequencing of every newborn or some subset of newborn. So these conversations will be played out over and over again in the coming 5, 10, 15 years, I predict.
Well, I think too, the underlying feature of all these is that when you're thinking about these studies, and I wouldn't limit it to newborns, we know there's 28 programs that have 28 adult programs right now across the country, at least 28. There's probably more since I last checked, where they're screening healthy adults as well. I think the key is these programs, we really need them to engage health economists to be doing these downstream studies as well, and helping generate some of the costs and revenue data, and where we're saving costs as well as where we're generating additional revenue.
By the way, I'm going to be a little edgy here because I'm not tethered to being a government employee anymore. But and so I can say this because otherwise, if I was representing the government, I wouldn't be allowed to say this.
This should be good.
Yeah, well, I mean, I completely agree with you. And I can tell you that the Genome Institute has been profoundly interested in enlisting health economics experts to help us study, to answer the very questions Colleen is referring to as we think about economic models associated with genomic implementation, whether it be testing, genetic counseling services, et cetera, et cetera, et cetera. We need our collective tent to include health economists. However, as you might imagine, the problem is that health economists also study the complexities of Affordable Care Act and healthcare, which is a highly polarized, highly political issue. And so what I can tell you in my years as the director of NHGRI, certain administrations allowed health economics research to go on at NIH and at our place, at the Genome Institute, and certain ones, they didn't want to. They didn't allow it. And so we were forbidden from doing that. So it is, again, when I refer to being at the adult table with real problems, this is a real political problem because, of course, I believe we absolutely have to have this research done. But there's a desire by some people at some parts of the political spectrum who don't look favorably to health economists because maybe they're going to reveal things that might provide facts into the debate about how we should be funding healthcare in America. I'll just leave it at that. And I think you know what I'm talking about.
Yeah. I think Brian brought up the good point about state laws and, different state policies will influence it. And that might be another place where, to Eric's point, you may not make progress on the national front, but at a local level, there may be some opportunities as well with state policies. But there's also good work happening in the Genomics England project. So hopefully we can learn some from them too.
And a corollary to what I said is we should be very supportive and very encouraging of health economists to look at these questions around genetics and genomics. And we should be very supportive of, maybe philanthropists or private funders funding these people to do the work at times where they can't get federal money from it, like through NIH. These are very important studies to be done. Maybe they'll be done abroad, and that's fine. But we need to get these studies done. And unfortunately, they've fallen into sort of the political sphere. And so they've been hindered in terms of getting research dollars.
Yeah.
Yeah. No, fantastic points of just that when we're talking about money, and especially, then it's like the government comes into play in the United States for this and just all of those factors that play a role in this. And we have so many questions in our Q&A. So I'm really excited. We're going to see how many we can get through in the next 20 minutes. So no more of my questions. We're getting to everybody else's questions. I don't know if people want their full names to be said. So if they didn't submit it anonymously, I'm just going to say your initials. So SR wants to know, how are we able to flex downstream revenue in other non-specific specialties? In pediatrics or critical care settings, a lot of times we talk about how we prevent costs, not how we generate. So, how do you flex that when most hospital systems are profit driven? Does anyone have thoughts to start us out?
I had a CEO who asked for downstream, but then ultimately said, "I just care about direct." So definitely can relate to that. How do we flex? I need to think about this one. How to flex down. I'm just rereading it.
Yeah.
Brian or Marianne?
Yeah, Marianne, do you want to jump in?
Yeah, so I'll speak first my experience in the prenatal or MFM setting. Of course, the procedures happening in the follow-up care happening in an MFM setting is different than in the cardiac setting where I did the research. So I've been thinking over the last year, what are my patients getting that's different as a result of their appointment with me? And so for me, examples of things I've seen in prenatal, carrier screening comes back positive for pregnant patient to be a DMD carrier. She's getting an echocardiogram and cardiology follow-up. We've had incidental findings that have led to referrals to pulmonology or neurology. I had been thinking about my impact on, the amniocentesis rate, but in my actual play out, I don't know how much, in one particular center that affects the rate of it. I would be curious to see that, but that's something to consider to look into. In like a pediatric or critical care setting, I think, again, it's taking that longer lens of first investigating, well, what are my patients getting that's different as a result of their time talking to me or their genetic testing, and seeing what that's like for your field. Maybe, again, they establish with neurology when they wouldn't have already. Maybe they were already established with these specialties. So I think it takes investigation into the patient population, what's happening after this appointment, and where are these patients being seen subsequently? What recommendations are we making for other family members? So I think there's some investigation. I don't have an exact answer on what that would look like in peds and critical care. I know that's a complex specialty too.
And then I would add cascade testing historically, and especially in the literature, supports that cascade testing rates are very low in many settings, and that genetic counseling can improve those rates. If you can mirror a model where you look and see what patients did I bring to the health system through a cascade testing process, how do my cascade rates look compared to other health providers in my system? I think that's really powerful data that can directly contribute to a downstream revenue conversation.
I think the other thing, so we did downstream revenue studies, which we haven't published yet in prenatal and cancer here. And when I know we're focused on the money today, but when I think about it, the money is one piece, but hospitals make decisions looking at a lot of different factors. And so, like, what are the other metrics that your hospital cares about? So when we did our prenatal downstream, we haven't gone through and figured out why, though it's pretty easy to hypothesize. It looked like babies were getting discharged from the NICU faster. That is a metric the hospital cares very much about, right? If you're having your genetic testing done prenatally, your NICU stay might be shorter. So I think there's the money aspect, but it's also what are the other, listening to your institution, and what are those other metrics that they care a lot about? And where are they really focusing? And then using the money along with those other metrics to make your argument.
Yeah. And we have another question about downstream revenue profitability. And for those that are watching live, the way I'm answering it is what got the most votes. So feel free to go through everybody and upvote what you want to be asked before we end. So this is an anonymous question. I would love to hear your insights, tips, tricks on how GCs can prove downstream revenue profitability when trying to bring genetic counseling to newer markets, thinking smaller healthcare systems without genetic counselors. This person goes on to say, I consistently hear from clinics, healthcare, that they don't have it in the budget to pay for services they quote unquote don't need, which we all know that that's not true. It's needed. But at the same time, that clinic is losing profits when they refer out. So lab and genetic counseling services as well as follow-up. Anyone have thoughts on that, Brian?
I definitely don't encourage anyone to make downstream revenue the only part of your argument. I think Colleen, I immediately see you smiling. In
Yeah.
administrative discussions, you bring everything to the table. You bring downstream revenue, bring direct billing revenue. You talk about how more appropriate testing is going to be ordered, and that's going to reduce downstream duplicative costs. Bring it all to the table, especially if they're talking about a new market. What is the need that they have? Why is this conversation happening? Key in on that first, and then make sure that you're including downstream revenue to say, hey, for that proportion of our consultative services that isn't pushing us over the line to profitability, here's where we close that gap.
Yeah, I agree 100%. And I think in some of these smaller markets, this is very much like reminiscent of a lot of conversations I have with small hospitals in Iowa. They probably won't see the same downstream revenues as a large academic medical center, right? Those higher profit procedures are going to be referred to the academic medical centers more often than they're going to be done at like a community health system. And so this downstream arguments aren't going to be the same. And that's where I 100% agree with Brian. Like, you have to focus on the other things. So are they looking for a COC accreditation, or what are the risks and liabilities to their institutions? What are the patients requesting and demanding? Thinking about like all of the facets and bringing that together as one. And I think that's where we go back to like the business case, right? Like, there's multiple components to a business case beyond just the financials. And so when you're thinking about strategic decisions, you need to kind of be considering all that information. And it can work, right? The University of Iowa wasn't like, we had 5 genetic counselors that were board certified in the state at the time, but we now have 27 in our health system alone. And then there's others in the state, and that's just, in 10 years. And it is possible, but you have to find the right strategic or the right strategies for each system.
Yeah, no, that's incredible. Just looking at, University of Iowa going, way more than tripling. I can't do the math in my head fast enough. Like, that's amazing to go from 5 to 20 something. I'm going to give a shout out to this person that has a question, Pam, because I think she would say that that's okay. We were just together on Friday at a conference, and I actually moderated a panel on the economics of genetic counseling. So I'm kind of coming off fresh from that. That was a good prep for today. So she asked, what is the conversation around it being more beneficial for hospitals to continue to bill under a physician at a higher rate than for GC's time, even if the Access to Genetic Counseling Act is passed? Colleen, did you want to take this one and maybe give a little background on access to GC?
Yeah, I can kick us off. I definitely want to hear what others have to say about this one as well. So the Access to Genetic Counseling Services Act is the federal bill that NSGC is about to reintroduce any moment now, which would recognize genetic counselors as Medicare providers. By recognizing us as Medicare providers, then we would not only be able to be reimbursed for our services when we see Medicare patients, but it would also help with being able to order genetic tests directly for patients with Medicare and perform telehealth for patients with Medicare. It'll have downstream ripple effects. But the first step is recognizing us as providers. In that bill, it does say that we would be reimbursed at 85% of what the physician fee schedule is. So Pam, I think you're right. Like, a physician would be able to bill more and get reimbursed more than a genetic counselor. That is true. Now, whether they should do that or not do that, there's going to be different codes. And this is where I would pass the baton to Brian. But also, if you're thinking about efficiency and time and how do you see all the patients, I don't think it's definitely the best model, though some health systems may need to pursue that model for a variety of reasons. But Brian's our code expert.
Yeah, so I love this question because it means that people are really thinking about like, okay, well, we see our APPs do this. They're seeing patients, but they're billing in a physician's name. So we call this incident to, right? Someone's performing a service that's being billed out in another provider's name. And we don't have the answer for you yet on whether or not this would be beneficial or not, because we don't know how Medicare is going to interpret the law once we get it. We're going to get there. And what we need to know is, are they going to keep 96041 when that passes? And if they do, what does the reimbursement look like? Because we're missing a professional work component to that. So if the code value goes up and it starts to eclipse what we could otherwise be able to bill with an E&M code, which is the physician code set used for billing, we would have to take a look at all those economics as a field to know what would be most beneficial for practices. But I think the most important bottom line is to remember that genetic counselors are primarily beneficial, not because we have more training than physicians, though with regards to genetics, we often do, but specifically because we are cost saving compared to the salary of most physicians. And so if you need a physician in order to perform the services from a hospital administration standpoint, that is a much more expensive service from their bottom line than a genetic counselor only service. And so we have to think about both sides. We can't constantly say, oh, we cost the hospital everything, but then pretend like physicians don't. Physician consultative services also include a physician salary in them. And so in that regard, it may be more beneficial for a hospital not to employ a physician just to supervise a genetic counselor for something that a genetic counselor is independently able to do.
Yeah, wonderful point that it's like you have to look at how much you're paying each person, and if genetic counselors are getting back 85% of what a physician would, but then you look at, well, how much do you have to pay that healthcare provider for their time? It might tip the scales a bit, so it makes more sense, the ROI for a genetic counselor to do that part. There's another question, Anonymous. Can the speakers please touch on looking at profitability of non-patient facing genetic counseling tasks, roles? So how do we impact overall institution profit and are in added value for research, lab work, coordination? So all the different types of roles that genetic counselors can have that it's not seeing patients and billing for patient time.
I mean, I could certainly answer it at a very high level by just
Please.
pointing out that the role of genetic counselors, or the roles, plural, has that list has just grown. I've seen it just grow across the entire ecosystem of biomedicine. I mean, most of what people immediately think about are clinical roles, but I think about the roles they play in the government, in the fund, in helping make decisions about in program work and for giving out grants at places like NHGRI, for major roles in research projects and research consortia, education roles, et cetera, et cetera. It's like I have to admit, and I knew very little about genetic counseling 30 years ago when I first came to NHGRI. Now there's a lot of the field has grown, of course, but I've just been really impressed over the last 10 and 15 years that every time I turn around, seems like a genetic counselor in a role that I didn't previously think would necessarily have a genetic counselor in that role. But then you sit there and you go, oh, that just makes total sense, and they're thriving. So, it is truly becoming a Swiss Army knife career where there's just a lot of different tools in that knife that genetic counselors can use. And so, profitability, I think the question was more, are they valued economically at institutions, whether it be a federal institution, a university, a health system, et cetera? I mean, I think the answer is yes, and they're growing.
And I think one aspect to consider with that too, I mean, I love that sound bit there, Eric, of like genetic counselors are becoming like the Swiss Army knife. Like, oh, which type of genetic counseling role are we pulling in here? And with that, it's also looking at, well, where are we saving time in other people's just like their consult time. If a genetic counselor, almost like I think about front desk staff. Front desk staff are not bringing in dollars themselves. But if all of us healthcare providers had to greet the patients in the waiting room, if it's a in-person place, oh, here's where the bathroom is, here's all the documentation, make sure everything's in the EHR. Okay, bringing them back, that would be such a not a good, efficient use of our time. We can see more patients when we have a team around us that has these different roles. So other like administrative people are not bringing in dollars directly, but we don't question, oh, well, do we really need this? Like looking at that. So I think that's one other aspect that I think about, that it's not necessarily this person is directly this amount of money.
I mean, just think about the roles they play as study coordinators with very
Yeah.
busy scientists whose time is much more high cost, and they get a lot done in making those clinical studies move forward, 100%.
Well, and I'd also, what's coming to my mind is somebody once told me when I was starting out or doing my PhD, they said, in academia, your currency are your grants and your manuscripts. And so if you're a genetic counselor and you have your own grant or you're on a grant, that is important to an institution. And a lot of academic medical centers are looking at how much grant dollars are we bringing in every year, not genetic counselors specifically, but the institution. And if you can be included in that, that is awesome, right? And that shows your value to the institution. And we have genetic counselors who are doing this really exceptionally well and have received a lot of grant funding. And there's programs to help others who are interested in this, learn from those counselors and become really great researchers as well that have, NIH funding or other funding that's open to genetic counselors and have those publications to back it up.
Yeah, and hopefully we see a lot more published genetic counselors like all three of you. I mean, Eric's been published not as a genetic counselor, but of just being able to show and the value there outside of just the dollars of spanning out from that. I think we have time for one last question. The next most popular question on our list is from VR regarding billing codes. I have listened to the DNA Today podcast several times and remember in the episode that Brian mentioned, so this is the episode that Colleen and Brian were on together, I referenced 9 months ago. Brian mentioned GCs in non-licensure states are more likely to be recognized by insurers if they are credentialed through a healthcare hospital system. I'm curious if you've seen contract providers successfully bill in non-insurance states after obtaining credentials through the hospital systems. Brian, I don't know if you remember talking about this, but any comments to VR on that?
Yeah, it's really nice when you can practice what you preach. I
Yes.
do work in the state of Texas. We are a state without licensure for genetic counselors. Every single one of our genetic counselors in our now 22 oncology genetic counselor practice is credentialed through the hospital. We bill under the genetic counselor's name using a professional fee in our name. It is not a facility fee. It's not billed under a physician. And we are absolutely practicing what we preach at UT Southwestern when we talk about billing. When we have billing problems, we go to the credentialing team or the payer contracting team, and we ask them to advocate on our behalf. When they're getting paid too little by one payer, we talk to the contracts team and get them to up it. So we can do this, and we've been successful in an unlicensed state at a state institution. So
Yeah, that is remarkable. I remember when you said that on the show, I was like, wow, you have found a workaround. And that is just so valuable. So I think it's just looking at what can we do to be able to bring more money back into departments, because then they're going to want to hire more people and they're looking at that ROI. And I think the team that you lead, Brian, is a great example of that. I wish we had time for all of the questions here and the questions that I had that I didn't have time to get to. Thank you so much, all four of you, Colleen, Eric, Brian, Marianne. I so appreciate getting all of your insight on this. I think for me, it's always fun to talk about the money side. I'm someone that I'm just so interested in financials. And so to be able to talk about that, I know we leaned heavily on the genetic counseling side, and I think a lot of the audience had a lot of questions in that genetic counseling space. So I'm, just so grateful that the four of you took time to come out and be with us live. Everybody that attended live, you're going to see a feedback link in your browser when this webinar ends. And we're also going to email it to you in case you're headed to that next meeting now that we're at the top of the hour. So we'd really appreciate you filling that out, because then we're going to get better feedback on what you all want to see in the Phenotype Speaker Series, because we've been going for 5 years now. I cannot believe last month we hit 5 years of the Phenotype Speaker Series. It was a COVID project, obviously, with that timing. And if you have missed an episode, I say episode, it's really a webinar here. We then have it all available as podcast episodes. So it's Phenotyp Speaker Series on all major podcast apps. Another way that you can get to it is by going to phenotyps.com, hit the resources tab, and then speaker series is going to pop up on that drop down menu. And all of our installments are on there, especially if you want to watch the video aspect. That's the best way to do it. And please stay tuned for our next webinar. We are always looking forward to having these conversations. And again, feedback on what you want us to cover or certain guests if you have suggestions and nominations there. So yeah, hope everybody has a great rest of their day, and everybody keep pouring their energies into the genetics and genomics fields so that we can get that return on investment and we can be making good money in the genomics and genetics space. So hope everybody has a lovely day. Thank you, everyone.
Bye-bye.